They actually have separate definitions. And health status disparities refer to variations in rates of disease occurrence and disabilities between socioeconomic and or geographically defined population groups. Next slide, please. So today we're meeting to discuss disparities around COVID-19. So I'm sure that by now many of us are well aware of what COVID-19 is, but just to lay the groundwork, we know that this is an illness. It's caused by a virus that can spread from person to person. We've just recently become aware of a mutation that allows the virus to spread even more quickly from person to person. This is a new virus. So when we talk to people in the community, often there's not a realization that when the term novel coronavirus is used, that novel means new in that context. It's a new virus that nobody had previously had immunity to. And so that's the danger of the virus, is that because it's novel, it's new. None of us prior to the availability of vaccines or being diagnosed with the disease ourselves had developed immunity. And even it's interesting that even when people have had COVID-19, it's not clear for how long that immunity lasts. Nor is it clear even with the vaccine for how long the immunity lasts, but we're hoping it lasts a long time, but that's still a bit of an unknown. The symptoms of COVID-19 can range from mild or no symptoms to severe illness. And so, of course, what we'll talk about in the course of the discussion today is the fact that older people and, in diverse communities, older can mean ages 40 or 45 and older, have much more severe symptoms due to COVID than other people. Next slide, please. So this is a map. This is the most recent map. I updated the slides this week, but the COVID-19 project at Berkeley hasn't updated the map since November 22nd, but this shows racial disparities in COVID-19 cases in the US, and the darker the orange color, the higher the rates of disparities. And you can see that South Carolina is kind of a slightly salmon colored, I guess you'd call it. So we don't have the greatest disparities in COVID-19 cases of all the other states. Next slide, please. However, nationwide, what we have seen is that Black communities in the US carry the burden of our nation's COVID-19 cases and deaths. Next slide, please. So these are data again, this is the most recent that I could find for race, infections by race. So on the left, where the blue bars are, you can see the total US population, and you can see that Blacks make up about 13% of the total US population. Then in the middle graph, you can see COVID-19 infections by race. And here you can see that Blacks have a higher rate of or percentage of COVID-19 infections than their representation in the general population. And when you look at COVID-19 deaths also, you can see that the deaths are highest among Blacks and Hispanics or Latino and Latinx groups relative to their percentage in the population. Next slide, please. So when we look at COVID-19 by race and ethnicity, and I thank Dr. Lefkoff for sharing this slide, this particular slide, we can see that when we look at on the left side, you have cases, hospitalization, and death rate ratios. And these are compared to white non-Hispanic persons. First column to the right, American Indian or Alaska Natives, the cases are 2.8 times higher than in whites, 5.3 times higher for hospitalizations than in Native Americans than whites, or American Indians than whites, and 1.4 times higher in American Indians than whites. But the group with the highest rates, when you look at cases, American Indians and Hispanics or Latino, Latinx populations have the highest case count compared to non-Hispanic whites. But when you look at the deaths, Blacks by far have the highest rates of death of any other racial or ethnic group. Next slide, please. So what are some of the contributing factors? Well, we can look at factors like multi-generational families living together in the same household. And this may be due to cultural reasons. Maybe it's a tradition in the culture for grandparents, parents, and children to live all together in the same household. It may be due to financial or economic reasons. There's a way to save money. If someone has a house and then other generations live in the house, the grandparents may be able to watch the children while the parents are working. But unfortunately, when you're in the middle of a global pandemic, having a multi-generational family is a major problem. Because if one person in the family was exposed to COVID-19 and they're told to go home and quarantine for 2 weeks and they live in a house with 6 people in one bathroom, how do they do that effectively? If one person in the family is actually diagnosed with COVID-19 and they're told to isolate for 2 weeks and they live in the same 6-person household with one bathroom, how does that work? So what we've seen is it doesn't work very effectively. And I know that a lot of groups around the country are really working hard to try to address the housing issue, and they're just trying to come up with solutions, but this is a massive, large-scale problem. You know, where do you send people to quarantine or isolate when they live in an overcrowded home situation? Next slide, please. Oh, I'm sorry. And you can see that Black majority neighborhoods have the highest rates of multi-generational family cohabitation. Well, 11.8% of Black families cohabitate, almost 12%, and that's higher than other groups. Next slide, please. So this map shows high-risk conditions, non-COVID high-risk health conditions above the national rates in the United States. And the reason this is important is that we know that these health conditions place people at risk of developing COVID-19 and then at risk of having more severe symptoms of COVID-19. And when you look at South Carolina, here you see the darker the purple, the higher the risk. We have a lot of purple in South Carolina. As the Southeast in general, even down to Texas, has a lot of purple, but South Carolina is, because we know that we have a population that already has a number of, not only where people have chronic conditions, but a lot of people have multiple chronic conditions. And that really affects the immune system, which some research shows places people at greater risk of developing COVID and also having more severe symptoms when they do get it. Next slide, please. So who are we in South Carolina? So we have about 5 million people here in the state. We're fairly evenly divided between males and females. And when you look here, you can see that South Carolina data are on the left and US data are on the right. So compared to the US, when we look at rural status, almost 34% of South Carolina is rural compared to 19% of the US as a whole. So we have a very rural state. Another factor that makes South Carolina unique compared to other states in the US is the fact that when you look at race, 27% of the state population is Black compared to the representation of Blacks in the US as a whole, which is 13%. We have a small but growing Hispanic, Latino, Latinx population, so it's more than doubled since I came to South Carolina back in 2005. So it's at 5.8%. When I came, it was 2.4%. And when you look at education and income, we are not as well educated as the rest of the country here in South Carolina, and that's reflected in the lower per capita and median household incomes in South Carolina compared to the US as a whole. The median household income for whites in the state is $54,000. For Blacks, it's $31,000. And for Hispanics or Latinos, it's $38,000. So these are some contributing factors to why we see Black people being just really negatively affected by COVID-19. And when we look at individuals below the poverty level, South Carolina has a higher percentage of people living below the poverty level compared to the US as a whole. So these are some of the social contextual factors of COVID-19 in South Carolina. And again, you know, we talk about aging, and the main point of this presentation is aging in relation to chronic conditions. And I think the important point to make is that many of the chronic conditions that affect older adults tend to be diagnosed in Black populations about 10 years earlier than in whites. And that's why I wasn't being facetious when I said, you know, for Blacks, it's, you know, we're looking at age 40 and 45 and older, where for whites, we might be looking at older ages. But if Black people tend to be diagnosed with diabetes, hypertension, and other chronic conditions at age 40 or 45, compared to when whites are diagnosed, that puts the Black community at greater risk of having poor COVID-19 outcomes. Next slide, please. So South Carolina, we have a rural population. We have transportation issues. You know, a lot of groups are doing a great job. I know Mr. Anton Gunn at MUSC has done a really marvelous job of getting COVID-19 screening or testing out to the rural areas of the I95 corridor. And other groups around the state are doing the same. And that's really great, because otherwise those groups would not get tested, because they have such distance to healthcare systems, much less distance to specialty care sites. And then we also want to make clinical trials accessible to people. So there have been a number of COVID-19 vaccine trials going on here. I know MUSC has participated in a number of trials. I don't know how many people from the I95 corridor were able to participate because of distance, transportation issues. And we have the Sea Island population, which we always want to keep in mind when we do research, because this is the least genetically admixed group of Blacks in the United States. And they also have strong cultural traditions that are where family is paramount. Communities are very strong. And the admixture rate of Sea Islanders is about 3.5% with European ancestry. And that's the lowest of other groups of Blacks are from 15 to 18 to 20% and higher admixture with Europeans. Next slide, please. So we are in trouble here in South Carolina. On January 6th, we reported more than 4,000 new COVID-19 cases, but even more concerning is that our percent positive, the test positivity, is above 30%. Next slide, please. What does that look like? It means that we had, as of yesterday, reported yesterday, but pulling data from January 5th at 11:59 p.m. midnight, we had almost 4,000 cases, and the percent positive was 34.2%. So the CDC recommends not reopening until cases, the percent positive is less than 5%. So the CDC considers anything higher than 5% to be high. So we're now at more than 6 times higher than the recommended level of 5%. And what's alarming is that what we're seeing are the post-Thanksgiving surges. We haven't fully realized yet the post-holiday surges from the past 2 weeks, because New Year's Eve was 7 days ago. Actually, it was a week ago, right? It was New Year's Day, New Year's Eve, New Year's Day. So we know people gathered together. So we're still seeing, it's expected that this percentage is going to increase. Next slide, please. So we know that the COVID-19 is very prevalent. Infections are prevalent in our state. What do the cases look like? Where are the cases? So we can see a cluster of cases along the coastline. We see in the I95 corridor in the middle of the state, there's another cluster, and then there's a huge cluster in the Greenville, Spartanburg, upstate region. So coastal area, Midlands, I95 corridor, and upstate. And the Greenville area is really having a very significant increase in the number of cases and deaths. Next slide, please. So let's talk just for a minute about the I95 corridor. So I was calling this, because I wasn't calling it this, there have been lots of articles written, and Congressman Clyburn has a document that he commissioned that's called the Corridor of Shame. So ever since reading that document that he and his group commissioned, I've been calling the I-95 corridor the corridor of shame. When I gave a presentation in December to the Department of Public Health Sciences at MUSC, and one of my colleagues pulled me aside after and said, you know, from the perspective of being a South Carolinian, when you use the word shame, that's kind of a pejorative term. And I said, oh, it doesn't mean, it's not that the residents should feel shame, it's the rest of the state that should feel the shame. But he said it's perceived as, so now I'm just calling it the I-95 corridor of economic disadvantage, which is what it is really. Many of us have driven on this I-95 corridor. If you venture off, let me just ask the group, what do you see when you venture off of the I-95 corridor? Has anyone ever just gotten off the highway and just driven around the area? So what's there? There's really almost nothing there, which is, it's mind-boggling, because in Greenville, we have the North American headquarters of BMW in Greenville. We have Boeing in Charleston, North Charleston. And yet you go, not even 100 miles to this I-95 corridor, and there is very little infrastructure to support the communities. Very few hospitals. In fact, I think it was Bamberg or Barnwell that went 2 years without a hospital in the entire county. So if you lived in one of those counties and had a heart attack or a stroke, called 911 and had to wait for an ambulance to come from MUSC or from Palmetto or somewhere else, the ambulance has to get to you. Then you have to get to the hospital. So you can see how that would really negatively affect your chances of survival and your health outcomes. Because if you have a stroke, you're supposed to get tissue plasminogen antigen or activator within 3 hours of the stroke. But by the time you have the stroke, your family recognizes the symptoms of the stroke. Someone calls 911, the ambulance gets to you. You may, and you finally get to the health system, you may already be out of that 3 hour window, which means you're going to have worse stroke outcomes. So the I-95 corridor has very few businesses. Dr. David Rivers at MUSC has done a really great work. He's done a lot of leadership development institutes all over the state, all over the country, trying to bring together people like the chief of police, the school superintendents, to try to pool their resources. Because the problem is that even when businesses go to these areas in the I-95 corridor, and they may be attracted because of the cheap land, you know, it's cheap for them to buy land and set up a business, they can't do it because they say, well, where would our employees' children go to school? Where would our employees get healthcare? They cannot, the businesses can't come because there's not enough infrastructure to support the people who would be working in the businesses. So we really need to do a lot of work to develop this I-95 corridor. But the I-95 corridor, because of the economic disadvantage, faces very unique health challenges in our state. Next slide, please. And so when we look at the areas of need, we can see that a lot of the high need areas are located in the I-95 corridor and neighboring areas. So these are areas where they need a lot of infrastructure to support the communities. Next slide, please. When we look at where persistent poverty is in South Carolina, for both persistent child poverty in the lighter blue and persistent child and total population poverty in the darker blue, much of the persistent poverty in South Carolina is located in the I-95 corridor. Next slide, please. So who lives in the I-95 corridor? I was looking at this and I thought, well, who lives there? How can we characterize the population? And so it's clear that not a lot of white people live in the I-95 corridor, because this map shows the percent white in population in the state overlaid on those high need areas outlined in red. And you can see that the majority of the white population lives in Greenville, the Myrtle Beach area, the PD area, coastal area, maybe near Augusta. I think there's a big retirement community and a famous golf course over there. But in the I-95 corridor, there are not a lot of white people who live there. Next slide, please. So then continuing the question, well, who lives in the I-95 corridor? This map shows the darker the green, the higher the percentage of Black population. And you can see that the darkest green areas of the state are in the I-95 corridor, where there's persistent poverty, lack of infrastructure, lack of access to care. Next slide, please. 75% of the counties in South Carolina have areas that are designated by HRSA as rural. And so we can see that, there's a lot of rural distribution across the state, but certainly the I-95 corridor has a lot of pockets of rural areas. Next slide. So how does that translate into health, which puts people at risk of having severe COVID-19 outcomes? When we look at diabetes prevalence among adults in South Carolina, the diabetes prevalence is clustered in the I-95 corridor. So this really shows that having economic disadvantage, lack of access to healthcare, it really reflects in diabetes prevalence. And again, we're talking people 40 and over with diagnosed with type 2 diabetes. Next slide, please. What about, let's look at diabetes death rates. So when we look here in the state, we see that along the top, we have Black males in the pale tan color. They have the highest rates of diabetes death in the state. They're followed by Black women in the blue dotted line, followed by white men after a significant gap, followed by white men, and white women have the lowest diabetes death rates. White women actually live longer than anybody in the country or in the state. Next slide, please. So let's look at heart disease. So the darker the red, the higher the heart disease mortality rates. So Charleston looks pretty good, right, for heart disease mortality rates. Maybe it has something to do with the availability of cardiac care here. Next, Greenville looks pretty good too. Oh, I'm sorry, I said next, but I meant next color, sorry. When we look at the yellow, Greenville looks pretty good. The I-95 corridor has the red areas where there are the highest rates of heart disease death rates in the state. Next slide, please. And then when we look at race and gender for heart disease death rates in South Carolina, we see again Black men have the highest heart disease death rates, followed by white men, followed by Black women, followed by white women, who again, white women nationally live longer than any other group in the country. Next slide. So HIV, another comorbidity that might make people have difficulty with COVID-19. Black men are almost literally off the chart in terms of reported cases of HIV in South Carolina. Next slide, please. So when we look at cancer, this map shows the rate of new cancer cases, the incidence of cancer in the US, and the darker the blue, the higher the cancer incidence rate. So you can see I've outlined South Carolina in gold. Next slide, please. So we just recently, I can't believe now it was November of 2019. We worked with the South Carolina Cancer Alliance, MUSC, University of South Carolina, Clemson, DHEC, a lot of groups came together to put together a volume on cancer in African American men in South Carolina. And we're really proud of this because it's the first volume, the first report that's ever focused specifically on cancer in Black men in South Carolina. And the reason we prepared this report is because the previous year, there was the South Carolina Cancer Alliance developed a report on cancer in South Carolina. And it was clear from that report that the disparities that we saw in the state for cancer, just as you saw for almost all the other diseases, are driven by Black men. Next slide, please. So we worked with then DHEC Director, Dr. Toomey, to put the report together. Next slide, please. And then next slide, please. So these are data that came out of that report. And we looked at the 5-year age-adjusted cancer incidence rates by race and gender. So again, Black men in the gold had the highest cancer incidence rates of any other group in the state, followed by white men, and then white women, and then Black women. This is incidence. Next slide, please. And when we looked at the cancer death rates, we saw that Black men have the highest cancer death rates in South Carolina. Thankfully, they're going down, the rate's going down, but there's still a gap between Black men in the gold, white men in the blue, Black women in the yellow, and then white women in the gray. Next slide, please. So when we look at South Carolina, we take all these factors into consideration, and then we look at COVID-19 outcomes for Blacks and Hispanics, Latinos, Latinx in South Carolina. And what we see is that Blacks make up 27% of the state population, 28% of the COVID-19 cases, 34% of the COVID-19 deaths. Hispanics or Latinos or Latinx make up 6% of the state population, 10% of the COVID-19 cases, and only 4% of the COVID-19 deaths. Next slide, please. So from these are the data from January 6th. This is why we're alarmed. I know many of us are alarmed about what's going on. These are the projections through April for the COVID-19 deaths in South Carolina. And you can see that trend is upward unless we start wearing masks and social distancing. So next slide, please. And then these are the daily death projections through April. Next slide, please. So what is the relationship between aging and COVID-19? Well, we know that older adults are at greater risk of requiring hospitalization or dying if they're diagnosed with COVID-19. And the risk for severe illness increases with age, but it also increases for people with comorbidities. And what we've seen is that Blacks in the state have a lot more comorbidities than whites. And these are tend to be diagnosed about 10 years earlier in Blacks than whites. So when we use the word older, older means something different in the Black population than in the white population if we're looking at age in relationship to comorbidity. And so we can see that people who are in their 50s are at higher risk for severe illness than people in their 40s, but we have to look at the intersection of race, and it may be very different. For Black people, maybe it's people in their 40s are at higher risk for more severe illness than people in their 30s. And so we see that the older the age, the higher the risk. Next slide, please. So this slide shows the relationship between aging and COVID. And, when I gave a presentation to the National Workmar Group, they were asking about the intersection of age, race, and COVID. And I just have not seen published data, but there was a group in Detroit that said they're working on a study to get the data. But we can extrapolate. That's what we're doing here, is basically extrapolating and using correlated approaches. But when we look at younger adults, in comparison, older adults are more likely to require hospitalization if they get COVID-19. So the 18 to 29-year-olds, pretty sure that's Brianna and Quentin, maybe others, not to call you out, but that's the comparison group for hospitalization on the left and death in the right column. So people who are 30 to 39 years old are 2 times more likely to be hospitalized for COVID compared to people who are 18 to 29 years old. And they're 4 times more likely to die. People who are 40 to 49 years old are 3 times more likely to be hospitalized for COVID than people who are 18 to 29, and they're 10 times more likely to die. And by the time you get to 50, it's 4 times higher for hospitalizations, 30 times higher for death, 65 to 50, well, that was 50 to 64, 65 to 74, 5 times higher for hospitalizations, 90 times higher for death. But if you scale it back down 10 years, you know, this is, I'm just putting a theory out there. If you scaled it, if you did look at the intersection of race, maybe what we see for 50 to 64 for the general population, maybe this is what it looks like for 40 to 49-year-olds who are Black, which would explain the much higher death rate among Blacks. Next slide, please. So we know that certain medical conditions can increase risk of severe outcomes for COVID-19, such as having underlying medical conditions. Next slide, please. And what are those conditions? The conditions that typically occur in people ages 50 years and older are cancer, chronic kidney disease, chronic obstructive pulmonary disease, heart conditions such as heart failure, coronary artery disease or cardiomyopathies, obesity, body mass index of 30 or greater, but less than 40 kilograms per, I forgot what the M stands for. And then severe obesity is BMI greater than 40. Smoking and type 2 diabetes mellitus. Next slide, please. Other diseases that could increase the risk for COVID-19 that occur more commonly among adults aged 50 years and older include cerebrovascular disease, which affects blood vessels and the blood supply to the brain, hypertension or high blood pressure, neurologic conditions such as dementia, liver disease, overweight, pulmonary fibrosis. So those are conditions that could affect increased risk for COVID-19. And we know that many of these occur in Black populations. Next slide, please. I thought this was really an interesting graph. It's so eye-opening. This was from a study called Excess Deaths Associated with COVID-19 by Age and Race and Ethnicity in the US, January 26th through October 3rd. And so it's showing the excess deaths from, they're comparing 2015 to 19 with 2020. So you can see clearly the excess deaths that are taking place during this COVID-19 pandemic compared to the time period of 2015 to 2019. Next slide, please. So these are data from January 3rd from South Carolina, age of COVID-19 reported deaths by race in the state. I mean, there is a, well, I guess I do have some data on the intersection, but not as much as I would like. Next slide, please. And then this is from January 4th. I guess the data are from January 2nd, showing who's dying in South Carolina from COVID-19. So only one person, three people were middle-aged, one person was a young adult, and everyone else is diagnosed as elderly, 65 and older. Next slide, please. So what are the social determinants of health, and how do they contribute to COVID-19 disparities in older adults? We've kind of been discussing them all along, but let's look at them in a little bit more detail. Next slide, please. So the Healthy People 2020 defines social determinants of health as conditions in the environments in which people live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And so place refers to environments and settings like school, church, workplace, neighborhood. Conditions refer to social, economic, and physical conditions. So we've taken a look primarily at the I95 corridor as place, and we've seen the conditions of the I95 corridor in South Carolina, the social, economic, and the physical conditions, and the effect on COVID-19. So let's go to the next slide. So we've looked at living in densely populated areas, but we've also seen that living in rural areas with few health and healthcare resources can also be a significant barrier to positive health outcomes and healthcare outcomes. Residential segregation, it was very clear that the I95 corridor the population is predominantly Black. And, you know, even in some of the urban areas, but definitely in the rural areas, there's a lot of distance from grocery stores and medical facilities. Multi-generational households, people may live together just to help the financial functioning of the family as a whole. But it makes it difficult to isolate or quarantine for COVID-19. And then we haven't even really talked too much about jails, incarceration, prisons, and detention centers where Blacks are overrepresented. It was interesting, I just read an article last week where a CEO of a company, oh, I know, it was the CEO of the energy company in South Carolina who was supposed to build a nuclear plant. And I guess he didn't. He was given, I think, $2 or $3 billion to build the plant, and he didn't do it, so he was prosecuted. And I think he was given 15 months in jail. But then you think about the person who robs the corner store who's given 25 years in jail or Mr. George Floyd, who was accused of stealing $20 and lost his life. So, you know, there's a lot of overrepresentation of Blacks in jails, prisons, and detention centers, and it's not because they're committing more crimes, it's because the crimes they commit are over-prosecuted. But those, we know that in South Carolina, I know there was a letter that was written just recently from the inmates, I believe, who are really concerned about COVID-19 and the spread, and they feel that they're not being protected in those environments. And I think the employees also wrote a letter, because we forget that the employees in jails, prisons, and detention centers are also imprisoned, and they face the same health issues that the inmates face. Next slide, please. So when we talk about social determinants of health disparities, some of my colleagues and I came up with these models back in 2014. So we have this is a very simple model. Social and environmental factors affect susceptibility to disease and access to healthcare, which affects health disparities. Next slide, please. This is a slightly more complex model where we have structural life inequalities affecting physical health disparities on the left, psychiatric or mental or behavioral health disparities on the right, mediated through chronic stressors and our behaviors. And, you know, I'm hoping that the pandemic has taught us empathy, because so many of us are stressed now with the pandemic. People are losing their jobs. People who have never had any type of financial troubles before are having them for the first time. And I'm hoping that that gives society empathy for people who face these challenges every day and who deal with the uncertainties and financial and food insecurities as a part of life every day. That now we understand what that feels like and how that might affect people's decision making. And because so many of my colleagues say they're eating more or they're drinking alcohol more because they're so stressed. You know, and if we're talking about very well-educated people who are using negative behaviors to cope with stress for something that we think is temporary, what about people where you don't see an end in sight? If you have a high school diploma in this country, this is how life is. It's uncertain. You can lose your job tomorrow, your car might break down, your kids might need medical care that you can't provide for them because you are not insured well enough, but you make too much money to qualify for Medicaid. So what do? You know, think about how inadequate you would feel as a parent if you could not provide your children with their basic needs. It's challenging. And if you have a lifetime of that, by the time you're 40, that really affects your health and your physical functioning. Next slide, please. So this is our final and most complex model of the interrelationships among the environment, stressors, negative health behaviors, and physical and mental health disorders. And the main point here is that by the time people are 40 and they're just constantly dealing with these stressors, one hypothesis that was really put forth by Geronimus was the weathering hypothesis, where she argued that because Blacks face such stressors from the time we're born, just that by the time we're 40, our bodies begin to wear out. And so she's suggesting that it's the weathering hypothesis, or the, which now there's some data to show that, facing stressors, physical and emotional stressors, may affect immune functioning. And so I think she was on the right track. And so that's one explanation for why chronic diseases tend to be diagnosed about 10 years earlier in Blacks than whites. It's the wear and tear on the body of this chronic fight or flight syndrome, where you may go to bed. It's like living in the Trump era, where, I mean, you go to bed and you think everything is fine, and you wake up and there's total chaos. And you think, what happened? But imagine that that's how it is for some people. They go to sleep and they have a job, and they wake up and their boss calls them and says, oh, you know, we have to cut back. Because when you have a high school education, you are expendable, because there are thousands of other people who can do your job. You know, I know that Dr. Lefkoff has a training program, and what we tell our students all the time is, the more education you have, the less expendable you are, because you can't just be replaced tomorrow if you specialize in something. You can't be let go and think that somebody else is going to just walk in. That gives you more security. But if you have a high school diploma, what do you offer that somebody else can't offer? So it's a very stressful way to live. You know, you may have a roof over your head one day, and the next day your landlord says, I'm going to sell, or I'm going up $200 a month on the rent. And so then you're throwing all your stuff together and looking for a place to live for you and your children. And so it makes it difficult. Your mailing address changes a lot. Your phone number may change a lot. People are just trying to survive, but it takes a toll on the body. Next slide, please. And so they're thinking that the sociocultural and biologic factors kind of work together to produce health outcomes. You have the diet, physical activity, environmental exposure, psychosocial stress. There are genetic and biologic variants and factors, but together they combine to produce the health status that we see in people. Next slide, please. So I just wanted to conclude. Well, first of all, I wanted to see if there are any questions, but I did want to show the flow. We have hope. I didn't want to end on a negative note. We have hope. DHEC published a vaccine schedule. So right now we're in phase 1, and that'll be followed, phase 1A for essential healthcare workers, and then that'll be followed by phase 1B, phase 1C, and then phase 2. So we have hope with the vaccine. Next slide, please. What can we do in the meantime? Wear a mask. Save lives. Wash our hands and keep a safe distance. So thank you so much. It's been a pleasure. I think there are some, I'll take questions, and then there are additional slides I think that need to be covered.
Thank you so much, Marvella. That was hard to listen to in parts, but it is so important. And I can't tell you how much I appreciate your sharing all of your, the time that, you know, that just to pulling together all that information in such an incredible way is really remarkable. I think one of the most important take-home points for me, and I hope everyone else really hears that, is your comment that you kept coming back to about how we age, how, everybody does. It's not like people turn old at age 65 in different population groups. You are aging so much earlier, and the implications that has on everything. And I so appreciated your focusing on that in how you kept coming back to the implications of that. It's just critical.
Thank you. And I think we see it in our communities, we see it in our families, we see it in our churches. Yes. We just see it over and over. People dying prematurely. Absolutely. Or just so debilitated physically, with diseases that don't occur in other populations until much later in life.
Yeah, I just want to reiterate Sue's comments, kind of the words I was thinking to help describe this presentation are that it wasn't just insightful, right? It was jam-packed with information, but it was really evocative. I don't know if that's a sign of the times, if that is certainly a testament to you in your presentation, but beyond kind of the facts and figures, really allowing us to think about the impact, current and potential future impact of this disease on our populations that are most in need. And talk about terms and terms being used. Minoritized is a term that I've been seeing being used more frequently, right? So not even just this perspective of minority population, but populations that are minoritized by virtue of their standing within society. So again, thank you for this presentation. Any questions or other comments for Dr.
Thank you. And I just wanted to add too that we are just at the tip of the iceberg, because there are people who are having long-term COVID issues, health issues. And so it'll be really interesting to look at racial and ethnic disparities in people with long-term COVID health issues and what that means for their quality of life, their financial security, because many people are not able to work. Even people who had good jobs before, they have such chronic fatigue now. They're having trouble working. So I think a long road ahead of us in this area.
I see a comment from Marty, is that Marty Davey, about saying, having worked for years with teens in lockdown, I was interested to see how you presented this in an academic setting. So comment there. If you want to add anything, Marty, feel free to do that. Or other questions or comments.
Did you mean incarcerated when you said lockdown? Is that, can you?
Yeah, yes, I worked with teens that were sent to us by the court. And then we had, we not only had a school, we also had therapy, and I was the dietitian there. So I worked on trying to figure out how could we, through the money that is through the school lunch, school breakfast program, how could we get them better nutrition? Because it's quite obvious that food changes mental capacity.
Absolutely, that's such important work. You know, if your breakfast is a ding dong or a ho-ho, you are in no condition to enter a classroom and start learning. Right. You haven't had any protein, no healthy fiber. It's everything affects everything, and that's a really important point about nutrition and just learning readiness of children. And that some kids who are incarcerated, it seems silly, but maybe if we had better, we could get them good nutrition, maybe that would affect their ability to concentrate in school and keep them engaged with school instead of other activities.
Well, I'm going to put down someone who's been doing that research. If anyone wants to look up what Antonia Damas is doing.
Thank you.
Thank you.
Other comments?
I think Colin Perriman has a question.
Is it okay?
Yeah, go for it, Colin.
Dr. Ford, wow. besides being speechless, thank you so much. It was quite the honor to learn from you. My question is, I studied the quality of education as it pertains to cognitive aging. From my understanding, we have better data at like years of education than like indicators of quality of education. Since you alluded like a lot to major elements of systemic racism via COVID, like, are you aware of forthcoming data that will integrate education and like quality variables like a COVID health to link it to like late life health outcomes, like, or health outcomes like for like adults or teenagers, to get to this, like, changing like the narrative that education is the great equalizer, even though it's not? Because we seem as aging scholars to be talking about health disparities, especially like between white people and Black people and other minoritized folks, but yet we still aren't like addressing those like equality and qualitative issues that speak to systemic racism. And so all of that, in short, what do we know of forthcoming data that will like allow us to have quality of education variables as it comes to COVID and cognitive health?
Wow, that is a great question. I don't know the answer, but you've hit on a lot of really important points. So let's start with education is not the great equalizer. It is not the great equalizer, but it does help to give people access to health insurance coverage and job security and safe housing, reliable transportation. It's not, you're absolutely right. It is not an equalizer, because in this country, a Black man with a college degree on average earns the same income as a white man with a high school diploma. So it's not an equalizer. However, a Black man with a college degree is going to have a more secure life than a Black man with a high school degree. So it's, education still can put people in a place where they can have a safer place to live. But I'm not familiar with the, what you were describing about education and COVID-19. That's a very interesting point.
Thank you so much. This is very, very helpful. I appreciate it, Doctor.
Thank you.
Thanks. And we're at 12:59, and maybe this is a question that you can answer relatively quickly, Marvella, because you mentioned a few people in Charleston doing some work. A question from Rebecca Kinsella: any ideas on how to get out the vaccine? Do you think there will be on the ground community programs to get people signed up? And just given her experience, there's been some technical barriers for trying to provide access for folks in the phase 1A category.
Yes, we know that if we back it out to the entire COVID-19 response, which has been less than stellar, then it's not surprising that the vaccine initiative needs a lot of really careful thought. I know that MUSC is doing a town hall on COVID-19 vaccines that's coming up. There's an organization called blackdoctors.com or blackdoctors.org that did a town hall, a national social media town hall last night at 7 p.m. I coordinate the Black faculty group at MUSC. We're developing, we've got to get it done this weekend, but we're developing a statement on our support endorsement of the COVID-19 vaccine. And we're also preparing a one-page plain language fact sheet that can be distributed to community members to help people understand in plain language more about the vaccine, more about COVID. So I think things are being done. I know that the state put together a COVID-19 vaccine task force. I didn't see anyone from any universities on it, but they have people from DHEC, the South Carolina Primary Healthcare Association, some community health centers, and other people. And then representatives of diverse organizations around the state. I don't know if there was a conscious decision not to include any academic people on that task force, but there must have been a reason for that.
Well, thank you for that response, Marvella. And Cheryl had a great comment, and I echo it about if you'd be willing to share your slides. She and I are working on an initiative, and even for my health disparities class this term, I mean, this would be a great overview for those students. So hope that you'll be willing to share some of what you presented to us today.
Yes, if you can put it into a PDF, and also I'd be happy to speak to your class as well.
Oh, great. Okay. So we'll talk offline about that. So please, everyone, join me again in thanking Dr. Ford for that presentation.
Thank you so much.
The emojis, thumbs up, hand claps, etc. So we're past an hour, but I do have a couple of quick announcements for you. So first, we'd like to announce our CADMR pilot project program. Many of you who are joining us today may already be aware, but we would like you to please share information about the pilot project call for proposals within your own networks. Each year, we fund up to 3 junior or mid-career scholars to conduct research in ADRD health disparities. Persons from any of our partner institutions who you've seen on an earlier graphic who fit our eligibility criteria are welcome to apply. And for more information, please do contact Mr. Quentin McCollum. Excuse me, and Quentin's contact information will be on our last slide, but also you can have them contact myself. My information is there, or Dr. Ford as well. Excuse me. Secondly, in order for us to continue offering health disparities and minority aging content that is of interest to you, and actually even the invitation for Dr. Ford to present today was based on earlier conversations about, how can we as a center address some of what we're seeing as it relates to COVID. And so we'd like to hear from you in terms of what more you'd like to see by way of seminar content. So we do ask you to please complete a brief evaluation to let us know how we're doing and to give us your ideas for future seminars. You can use the QR code that's pictured here on this slide, or also at the conclusion of the seminar, we'll be emailing you a link to complete the survey, okay? And then lastly, if you are interested in upcoming seminar events and the such, please, that are sponsored by our CADMR, please do contact us. Our website, our website and our center name is Googleable. So the actual link to our website is quite long. We're working to maybe have a tiny URL in the future, but if you actually put in Google CCADMR or at the, in the school at the USC search toolbar, you'll be able to find our website and information about our calendar of events for the year, as well as other activities that we hold as a center. Sue, Daniela, as our PIs, any other information to share?
I'm so sorry, I meant to thank Ms. Brianna Ashford Carroll and Mr. Quentin McCollum, because they were amazing in preparing for today, and we did a trial run yesterday. Thank you.
Very good, very good, yes, and their information
I just want to thank, I'm sorry, I didn't mean to interrupt. I'm terrible at, I always talk over PI people, and I apologize. I just want to thank Marvella again for this really important hour that I think, we are all feel it's really an important hour that we are privileged enough to be able to listen to and hopefully work toward in our research, making some changes in all of the above.
Thank you. It's a privilege to be here with everyone. Thank you.
Very good.
Thanks again.
All right, well, thank you all for joining us. Our next public seminar is scheduled for March 5th, so do be on the lookout for information about that. And the topic scheduled is for technology and aging. So if you're interested or know of colleagues who will be interested in that topic, we hope to see you then. All right, thank you all. Have a great day.
Thank you.
Bye.
Thank you.